on to the core topics which are coming in obstetrics, because INICT is very heavy on core obstetrics, and the topics which they are very fond of are PPH and hypertension in pregnancy. So these two topics I have tried to deal with them in this session as well, and of course anything else you guys want to ask me, you're more than welcome. All right, so let's start right away, guys. So this is the last resort revision, your fighting chance for NICT, and let me tell you that from 17th to 21st of April 24, you'll be having this champions exam of INICT, where you'll be part of the 90% of students who are taking the INICT exam who will be appearing for this exam, and you can gauge yourself how much how deep in water you are, or how high in the sky you're flying. And we'll be doing all the last year PYQs, and we'll be making sure that you get accustomed to whatever the topics are coming in the exam. And of course, you'll also get to have a rank in this, so you'll know where you stand. And please remember, this will be a real exam type of a simulation. Right, we'll start with the questions, guys. The first question here, volume. There's an issue of volume. Can you just check, my friend? Something regarding the volume? Okay. Can you give me a thumbs up if you are able to hear me well now? And something about the volume they've done. Yes, I think you guys can all hear me well. So, what is the condition? Is the parental transmission is the least. Now, if you see herpes simplex virus, rubella, and then there, just a minute, I have to cut the volume here. Yeah. Herpes simplex virus, rubella, hepatitis B, and cytomegalovirus. So all of us know this TORCH group of infections are the ones which we are worried about in these abortions. Please remember, TORCH does not cause recurrent abortions. That is something which keeps coming in the exams. And if a person has had an abortion with rubella, next time she's immune to it. Similarly for cytomegalovirus and herpes simplex virus. So does not cause repeated abortions, and also the patient who's got these infections, they can be transmitted perinatally, and they can also be transmitted during the antenatal time. But the infection of hepatitis B, HBs, AG, and hepatitis A also. Okay, hepatitis A and hepatitis B, they are not transmitted during the pregnancy. Hepatitis A, they say it may have a transplacental transmission, but that's very negligible. So for all practical purposes, when we are reading for our exam, hepatitis B, hepatitis A does not transmit during the pregnancy. It transmits only during labor. It is got hepatitis B transmission is peripartum. Okay, it is called a peripartum transmission. And yes, if the mother is positive, is having the antigen present, then there's up to 90% chance that the baby is going to get it. All right, so be very careful when the baby is born. We take care of the baby by giving the active and passive immunity at birth. All right, so that's about this question. Anything else you guys ask me about? Okay. Rubella is the maximum. Yeah, somebody is discussing answering rubella. So rubella is got a very high chance of transmission in the first trimester. Rubella in the first trimester is almost 90%, and in the second trimester it is still around 60-65%. End of second trimester it's still around 25%. So rubella is that classical teratogen. It's that perfect teratogen, and sounds like an oxymoron, perfect teratogen, but sounded like an oxymoron, but yes. So it's that teratogen which is a very high chance of transmission and causes a lot of destruction in the organogenesis, and that's why if a patient has high IgM during the pregnancy and the IgG is low and it has not started coming in the circulation, and then we start counseling the woman that we'll probably have to end this pregnancy, we'll probably have to do an abortion, right? So we'll see the next question. Which of the following is not a criteria for preterm labor? That's a good question. Cervix more than 1 centimeter dilated, contractions of 8 contractions in 60 minutes with cervical changes, slight grammatical mistakes here. Then more than 80% effacement of the cervix, and cervix directed posteriorly. All right, come guys, shoot. B. Are you answering for this or something else? Sonal Narwani, are you answering for this question? Wait a minute. A, D. All right, cervix should be directed anterior. That is what one Dr. Soumya has said. Well, guys, you must understand the position of the cervix normally and what happens when the uterus becomes bigger and when the patient is going to labor. So, yes, the answer indeed is D, because when you look at the cervix, normally, if you see, let's say, early pregnancy, yes, cervix is downwards and forwards. This is how the cervix is. Suppose this is an early pregnancy like this, cervix is downwards and forwards. All right. Now, as the uterus becomes bigger, with a larger baby, you can see that the cervix becomes anterior. Okay. So, there's a big baby here and now the patient is nearing term. You can see the cervix is not directed posteriorly. So, normally the cervix is, anteverted and downwards and forwards. Now, as the uterus becomes huge, the weight of the baby will make the uterus fall back. So, cervix will become mid position and then around the time of labor it will become a little anterior. So, cervix, if the patient is going to labor, will never be posterior. It will be actually, maybe it will be in the midline, okay, it will be medium somewhere, or it will be anterior. So, midline or anterior, anterior is what we want to see when the patient is going to labor. So, yes, cervix directed posteriorly is wrong. So, all the others are correct and cervix directed posteriorly is the answer to this question, right? Did you all get it? Yes. Okay, so Bishop score, some people are talking. So, yes, I actually kept this as the next slide. So, remember, Bishop score is something which you have to learn. You have to mug up this table. Anyone having, some of the FMG students asked me in the previous LRR that, so do we really have to remember all of the criterias, all the parts of the Bishop score? Please, yes, you have to remember this. This is that table, you have to mug it up, because we'll be telling you in the exam, cervix is 2 centimeters dilated, it is medium consistency, it is 50% effaced, and it is anterior, and the station is -2. What is the Bishop score? Something like that we'll ask you, and you have to immediately just calculate everything and give the Bishop score. So, this has to be mugged up, okay? No exceptions. So, please read this now nicely. So, what I want to tell you here is that we mostly ask you the effacement in percentages in most of the exams. So, 0 to 30% effaced, 40 to 50% effaced, 60 to 70%, or more than 80% effaced. But yes, this is why I have given you the other method also of measuring the cervical length, that is the cervix, how it keeps getting taken up. If you see the length, if you look at my hand and my hand is the cervix keeps getting effaced like this. Now, this is like a 50% effaced cervix, this is like a fully effaced cervix. Now, we can also say that the normal length of the cervix is 4 centimeters. So, it is now 3, it is now 2, it is 1, now it is a 0 centimeter cervix. So, when we say the cervix is getting taken up, we can say the effacement in percentages, or we can say it in centimeters. So, either way it can come in exam. But what I am telling you, that in the last 3 years, wherever it has come, either it has come in the MCA exam or in the AIMS exam, it has come as percentage. So, might as well remember the percentages if you feel that you want to mug up lesser. But if you know all the 5 criterias, 4 are pertaining to the cervix and 1 is pertaining to the head, the station of the head. You must remember it properly. All right. This is going to be one easy question and straight away marks for you. Now, we are talking about preterm labor. So, the criteria for preterm labor is at least 4 contractions in 20 minutes or 8 contractions in 60 minutes. On per vaginal examination, the cervix should be more than 1 centimeter dilated and more than 80% effaced. And if the cervix is more than 1 but less than 3 centimeters dilated, we call it early preterm labor. And if it is more than 3 centimeters dilated, we call it advanced preterm labor. Now, that is the criteria of preterm labor. Something else I want to tell you here itself, that if a patient is in preterm labor, there are some things which you have to mug up. Please, if a person is in preterm labor and the labor is between 34 to 37 weeks, actually we write 36 plus 6, but for ease I am writing 34 to 37, then we do not give tocolysis, because the lung is mature. So, less than equal to 34 weeks, if there is preterm labor, that's when we give tocolysis, okay, because the lung is not mature. So what is the purpose of tocolysis? The purpose of tocolysis is to buy that crucial 2 days of time. Please, if a patient is 2 centimeters dilated and she's in preterm labor and you give tocolysis, you're not going to stop labor forever. Please, you're not going to stop labor at 33 weeks and feel that, okay, now I'll continue the pregnancy till 40 weeks. That is never going to happen. If you diagnose preterm labor, it is a patient who is in actually labor which is preterm, then whatever you do, you're not going to get more than 2 to 3 days. That is if there is a true preterm labor. Okay, so if a patient has labor and she is 33 weeks, you try and get those crucial 2 days at least. You may get 3 days sometimes, so you're not going to get more than that time. So the purpose of giving tocolysis is to stop preterm labor so that you get 2 days, so that the patient is given the steroid for the lung maturity of the fetus. All right, that's the purpose of tocolysis. Number 2, tocolysis is given only before 3 centimeters dilated. Cervix is less than equal to 3 centimeters dilated. She is in preterm labor, and that is known as the latent stage of preterm labor. So in latent preterm labor, your tocolysis will work. So tocolysis, two things I told you in this class: less than 34 weeks of gestation and less than 3 centimeters dilated. That's when your tocolysis will work. If the patient is 4 and more, yes, 4 and more is active stage of labor. And if the patient is in active stage of labor, whatever you do, whichever type of tocolysis you give, it's not going to work. All right, you can sit on the uterus, she'll still going to deliver. If you sit on the uterus, she'll deliver faster. Anyway, forget that part. So please remember, patient less than 3 and less than 34 weeks is the tocolysis. Now, let's see something else. How do you predict preterm labor? Quick revision of our facts. If you do an ultrasound, this is straight from the previous edition, the prepladder notes. I'm trying to just show you that around 12 to 13 weeks, if the cervix is less than 2.5 centimeters, it's a short cervix. So you're already having an idea that around early pregnancy, that is first trimester, if the cervix is short, you are worried that if it is in the beginning of the pregnancy itself, it is 2.5 inch shorter, that means it's going to, because a long cervix will take 40 weeks or 37 weeks to efface. But if the cervix in the beginning of the pregnancy itself is just half of it, it is just 2 centimeters suppose, then it is going to efface faster and she can expel the baby at 24 weeks. Abortion or a short cervix can efface at 32 weeks and expel the baby. Now we call it preterm labor. So before 28 weeks we call it an abortion. After 28 weeks to 37 weeks we call it preterm labor. A short cervix can cause that. So remember that part, less than 2.5 centimeters can predispose to preterm labor. And also another ultrasound at 29 weeks of gestation, if you see funneling of the cervix. So if you see that the cervix, this is a normal cervix. Can you see it's a T here? Can you see this? There's a T-shaped cervix, the internal os. This is the external os and this is the internal os. Internal os is closed, so the cervix has a T-shaped canal. Okay, now here you see, I'll try to shade it and show you this way. Okay, here you see the cervix is getting to have a little bit opening at the internal os and the membranes will start bulging into this cervix. So that is known as funneling. And now this is much major amount of funneling, and this is the funneling which is just before the delivery of the baby. So if there is first sign of funneling is a Y-shaped cervix, and just before delivery, a U-shaped funneling is the kind of funneling you see. So they'll ask you this question. This has actually come in your exam, that what is the type of funneling which you see just before the patient is about to deliver. So a U-shaped funneling of the cervix. Okay, so normal is T, Y is the earliest, V is the next, and U-shaped funneling is just before expulsion of the fetus. All right, right, guys. Then, okay, any questions you're asking me about this? Okay, let me just get back. Marva sir is here. Oh, wow. Hi, Dr. Marva. Guys, I'm having quite an audience here. Okay, come, guys. Okay, you're not asking me anything else. Okay. Chalo, we'll keep it at this one. We'll go to the next question, guys. And all of the following are the causes of non-immune hydrops except. Come, guys, shoot. Non-immune hydrops. All of the following except. B, B, D. Okay, there's between. Lion King, yes. My friend King, you're here since yesterday. I'm great to see you again. Yes, fibronectin. Fetal fibronectin is another prediction. Okay, vagina having fetal fibronectin in the secretions before 37 weeks is prediction of preterm labor. When you see fetal fibronectin in the vagina, in 1 week there's a 40% chance, and in 2 weeks there's a almost 80% chance that the patient will go into labor. Fetal fibronectin should be coming in the vagina only after 37 weeks. That's also correct. Okay, we are into non-immune hydrops, guys. So hydrops fetalis. Hydrops means fluid in the baby. The baby is full of fluids. That is what is known as hydrops fetalis. Now, a baby can fill in fluids because of so many reasons. Apart from RH isoimmunization, RH isoimmunization is known as an immune hydrops fetalis, and the baby accumulating fluid in the body because of any other reason other than RH isoimmunization is known as the non-immune hydrops. And there are, yes, once I counted the number of events which can cause non-immune hydrops. There are 53 causes which are mentioned in Williams obstetrics. All right. So please remember, non-immune hydrops is the most common cause of hydrops. So hydrops fetalis most common is non-immune. Now, when there is non-immune hydrops, in this the most common are the cardiac causes and the chromosomal causes. Cardiac and chromosomal causes. All right. Of course, they can be thalassemia, alpha thalassemia causing HB BARTs that can cause, and parvovirus is the most common infection. I mean, your pediatricians are so fond of teaching you this parvovirus, the B19 infections, the lace like erythema, and the slab cheek appearance. The erythema makes that kind of an appearance. So yes, you guys know about parvovirus very well. It's the most common infection which causes non-immune hydrops. Cardiovascular causes, in this one of the most common causes are the cardiovascular and the chromosomal. Now, in cardiovascular, which is the most common? In cardiovascular, the most common is the congenital heart block. All right. Now, ABO incompatibility causing causing hydrops fetalis can happen. Okay, but that is a immune cause. So answer is actually D. So those who answer D are absolutely correct. So that is what we are saying, that non-immune hydrops and immune hydrops. So immune hydrops can be because of RH isoimmunization, ABO incompatibility. ABO incompatibility is what? The mother is let's say A and the baby is B, and the B blood group comes to the mother's circulation. So mother makes antibodies to the B antigen. So that is immune, isn't it? Immunity is working there. So RH isoimmunization, ABO incompatibility are the immune causes of hydrops fetalis, and rest all are the non-immune. So deliberately, I think they gave you a question where they did not write RH isoimmunization, because you know RH isoimmunization causes hydrops. They wrote ABO incompatibility. If you're not reading regularly, you may actually miss it. So ABO incompatibility, RH incompatibility causes hydrops fetalis, which is immune. Rest all the causes where the baby gets filled up with fluid are known as non-immune. Even a cystic hygroma, a big swelling next to the neck, lymphatic collection, that is also a non-immune hydrops. Okay, one more thing I want to tell you about this RH incompatibility along with ABO incompatibility. So yes, RH incompatibility is one of the favorite topics of our app, and please go and have a good read on this one. But remember, if a woman is RH negative and she's A negative and the baby is B positive, so what happens that when the baby's blood comes to the mother's circulation, baby has sent B antigen and the D antigen to the mother. So now there's a war at two fronts. One is the ABO incompatibility, the other is the RH incompatibility. So moment the B blood group comes into the mother's circulation along with the D antigen or the RH antigen, the mother recognizes the B antigen first. Moment the mother's immune system recognizes the B antigen, the B antigen carrying RBCs are immediately destroyed, destroying the Rh antigen also in the process. Once again, moment the B positive group comes to the mother who's A negative, this mother mounts an antibody response to destroy the RBC carrying the B antigen. Once the RBC carrying the B antigen is destroyed, the Rh antigen is also destroyed. So the mother's immune system does not get exposed to the Rh antigen at all. I hope you understood that. You can always rewind and listen to this again. So please understand that having ABO incompatibility along with Rh incompatibility is protective against Rh isoimmunization. Okay, I'm sure some of you knew that. Most of you knew that. Of course, you're reading for the Inicet exam, so most of you knew that. But for that one guy who did not know this, this is for that guy also. All right. So, any questions you're asking me here? No, you're not asking me any questions in this. You're listening. Good. Okay. So let's. Any questions about Rh? No, you're not asking. Okay, let's move on. Which of the following coagulation factors decrease in pregnancy? Yes, guys, come. Which of the following do you? That's an easy question. Like I told you yesterday, AIMS exam, AIMS JIPMA PGI, INICET exam is known to spring out some very simple questions and then some outright tricky ones also. Guys, you're not answering? Or is there something wrong with my lappy? No, you're answering. Anti-D dose, Chandrakant. Anti-D dose, yes, we must, after 12 weeks, we should give the complete dose, whatever events are happening. Okay, 300 micrograms is the complete dose. And 300 micrograms, sometimes they'll ask you in units, 1500 international units. So if it is 300 micrograms, see the micrograms if the unit is there. Then after 12 weeks, that's the dose. For any event, if there's an amniocentesis of this, there is a, patient is having an external cephalic version or the patient delivers, the dose is 300 micrograms. Before that, there's a variation in the doses, can be from as low as 50 to up to 120 micrograms. People, some books say that you can just give 50 micrograms before 12 weeks. Some books give a range 50 to 120 micrograms. So anything before 12 weeks, that is, let's say an ectopic pregnancy or an abortion before, you can give 50 to 100, 120 micrograms. All right. Okay. Right. So what have you answered, guys? Okay, 11 and 13. Yes, I saw one person answering. So 11, factor 11 is the one which decreases in pregnancy. Rest all the factors increase. So 11 and 13 are the two. So I'm giving you the slide here from the physiology of pregnancy chapter of our app. Clotting factors in pregnancy increase concentration of all the clotting factors except 11 and 13. All right. So please remember something about fibrinogen. Fibrinogen is that very important increase in pregnancy. So fibrinogen is average 300 milligrams per deciliter in a non-pregnant woman, and it increases to average 450 milligrams per deciliter in a pregnant woman. So a pregnant woman has a increased capacity to coagulation. It's a hypercoagulable state. So it's good, right? Every time she bleeds in her delivery, when she bleeds in her delivery, any woman, even if you do a very good, active management of third stage of labor and you prevent PPH, some bleeding is going to happen. So if the placenta, when it is separated, the base of placenta is where it is going to be bleeding the maximum. So base of placenta has more coagulation as compared to a normal woman. So a normal human for that matter. So increased coagulation, so bleeding at the base of placenta will be reduced. So it's a good preventive measure against blood loss to have more coagulating factors in pregnancy. It's a hypercoagulable state. All right. Love for medicine, that's a question which we'll answer at the end of the session, my friend, because we are doing outright discussion of topics. So we'll come to that question. Okay, now clotting factors, these are the clotting factors. I'm sure all of you know that, but if you want to quickly see those clotting factors where you want to just see the list, I've just got it for you here. Okay, now let's move on. Which of the following is related to the Kasovich rule? All right, Dr. Preeti, I hope I'm not getting into your territory here, because this Kasovich rule has come twice in the INICT exams, so I cannot just ignore it. Yes, it's a microbiology related question. So what are you going to tell me? Latent syphilis, primary syphilis, secondary syphilis, congenital syphilis. All right. So yes, this is a sitter, and okay, fine. Guys, all 212 of you are immediately answering D. All right. Thank you so much, guys. So congenital syphilis, yes. It's written here, but I'm just going to tell you that a woman may abort a child in this pregnancy, let's say at 8 weeks. Next time she'll abort the child, let's say at around 18 weeks. And probably the third time she's going to have a preterm labor around 30 to 33 weeks or intrauterine death. And maybe the fourth time she'll have a live healthy baby. So progressively better outcome as the number of pregnancies happen. Okay, progressively better outcome with congenital syphilis. All right, that's what is the Kasovich law. All right, I've written that for you. Now, just a quick revision of details here. So, early congenital syphilis from the first 2 years of life, skin rashes, mucus patches, lymphadenitis, hepatosplenomegaly. Late congenital syphilis from the second year to 30 years of life, mostly asymptomatic, and is diagnosed by only the serological testing. It has interstitial keratitis, 8 nerve deafness, and Clutton's joints. Clutton joints, symmetrical swelling of the joints, mostly of the knees. Then stigmata of the early congenital syphilis is saddle nose deformity, Hutchinson's teeth, raggeds, and onychia. Stigmata of late congenital syphilis, perforation of the palate, corneal opacities, optic atrophy, periosteal tibial changes. And you have to mug it up. All right. So hate me for this, but go ahead and mug it up, please. They can just ask you any of this in your exams. I'm sure the medicine guys and the derm guys are always teaching you this very well, but might as well one more list from my side. And it's good to remember more and more details about syphilis keeps coming in exams, guys. Okay. Regarding pathogenesis, all right, guys who are getting distracted and having chit chat going on here and there, please now get to this question. PIH and PPH, they are two chapters which are very, very famously coming in INICT exams. So please, regarding pathogenesis of preeclampsia, which of the following is incorrect? I'm asking the wrong option. This question actually should be formatted as all of the following are correct except, like that. So there's an increase in the soluble FMS like tyrosine kinase 1 and a decrease in placental growth factor, increase in SFLD1 and decrease in placental growth factor. Vasoconstriction leads to ischemia, necrosis, hemorrhage, and end organ damage seen in preeclampsia. This looks like a correct answer. I mean, this is a correct option. We have to check, we have to mark the wrong option here. Endothelial cell dysfunction leads to reduced nitric oxide levels, and this causes the clinical presentation of preeclampsia. This is absolutely correct. There's a decrease in thromboxane A2 and increase in PGI2, that is prostacyclin and thromboxane A2 ratio in preeclampsia. So yes, guys, I'll make it easier for you. Answer is between A and D. Come. Let's say, what are you guys picking up? B and C looks correct to me. What about A and D? So, those who are yes, go pick up P. So, that's like, this is a adage which we always teach you. The more complicated the question is, it actually becomes very simple, because all of you know that thromboxane A2 increases in pregnancy. So there is this one line here which says there's a decrease in thromboxane A2. If none of the other three choices made any sense to you, you should have just looked at this one, and that's why I think most of you got it correct also. You guys know the tricks by answering so many MCQs in your exams. I'm sure you all know the tricks how to get along and how to answer all these MCQs. Good, guys. So there's a increase in thromboxane A2 and there's a decrease in prostacyclin. That's what is seen in preeclampsia. So yes, D is the answer. This does not happen. Okay, this is the answer to this question. This does not happen in preeclampsia. Yes, there's an increase in soluble FMS like tyrosine kinase 1 and decrease in the placental growth factor. This is also correct. Okay. Fine. D is the answer to this question. Now, quick revision. All of us should look at this. Remember that when there is a pregnancy, the extravillous cytotrophoblast. See this extravillous cytotrophoblast. This also came as a question. Extravillous interstitial cytotrophoblast and the cytotrophoblast which is endovascular extravillous trophoblast. All of these questions have come in your exam. So please see this picture very closely and revise this with me. Okay. So when a patient, this is the syncytium, these fronds coming, syncytotrophoblast, and these are the cells here, cytotrophoblast. So these cells come out from the villi and they come into the interstitium and then they come into the blood vessels, and the blood vessels, the spiral artery, see this is the maternal side, this is the maternal side of the placenta and this is the fetal side of the placenta. So what's happening, you're seeing that the spiral arteries which are giving blood supply to the interface between the placenta and the uterus, so that spiral arteries, they will lose the smooth muscles because there will be invasion by the cytotrophoblast. So this cytotrophoblast replaces the smooth muscles, and can you see the blood vessels is so much bigger in diameter. So that bigger spiral artery gives much better blood flow to the placenta. Now what happens in a patient with preeclampsia? Can you see this invasion, trophoblastic invasion is much lesser. So you see this spiral artery here. This spiral artery is still having that red lining which is the smooth muscle lining. So that is going to cause vasospasm, and vasospasm is going to reduce the flow towards the placenta, and that reduced flow is going to compromise the baby's perfusion, and to give better perfusion to the baby, the mother has an auto-regulation to increase her blood pressure. So yes, that's what we always say, to overcome this vasospasm here, look here, this is the vasospasm, please. The basic pathology of preeclampsia is vasospasm. Why it is happening? Because of persistence of the smooth muscle layer. Why? Because of inadequate trophoblastic invasion. So this vasospasm is the reason why the mother increases her blood pressure. Now, this is one part. Now, let us see about the other things. So, in a normal pregnancy, how does the angiogenesis in the placenta happen? What happens to the placental vasculature? So, angiogenesis, good healthy blood vessels, if they are formed in the placenta, it is good for the perfusion for the baby. All right, makes sense. So, good angiogenesis should happen in pregnancy. So, for that good angiogenesis, we have the transforming growth factor, we have the vascular endothelial growth factor, which is going to act on receptors in the blood vessels and cause the blood vessels to grow in size and become dilated in size. So this is a normal pregnancy. In a normal pregnancy, the transforming growth factor and the vascular endothelial growth factor will act on the receptors on blood vessels and help the angiogenesis, make good healthy dilated blood vessels, big diameter blood vessels. Now, what happens in PIH here? Can you see? In PIH, there is something called the soluble endoglin. Soluble endoglin here. This and the soluble FMS like tyrosine kinase 1. These two are now commercially available tests. That's why they are asking you these questions. Last 2 years, they are asking you much detailed MCQs about the etiopathogenesis of hypertension, pregnancy and preeclampsia, because these are now not so easily, but in the major metros, we are having these tests. So if a person is having soluble endoglin and soluble FLT1 increased in a circulation, what are they going to do? They are going to inhibit the binding. Can you see the vascular endothelial growth factor and the transforming growth factor? Now it is not able to bind. See this binding here on the receptors of the blood vessel is paramount for angiogenesis. Now can you see this SFLT1 and soluble endoglin is inhibiting the binding of transforming growth factor to the receptors on the blood vessels. So angiogenesis doesn't happen. That means the blood vessels don't form properly, big diameter blood vessels don't form, and that's why there is vasospasm. So that's why high soluble endoglin and high SFLT1 is indication that if there is high in the circulation in the blood tests which we do, then this patient is going to get into preeclampsia later in pregnancy. So that's what causes endothelial dysfunction. Right guys, so after understanding this, a quick revision of what I told you just now. Trophoblastic overproduction of two anti-angiogenic overproduction of two anti-angiogenic peptides, elevated SFLT1 and elevated soluble endoglin. These are the two things you have to remember. All right. So once we remember this, then we know the pathology of this. Now these along with low platelet growth factor concentration correlate with preeclampsia development after 25 weeks of gestation. Right, guys? So, along with this, now let me just summarize things for you. There is reduction of endothelial prostacyclin. There is thromboxane A2 secretion by the platelets, which is increased. So, prostacyclin, this is a vasodilator. Thromboxane A2 is a vasoconstrictor. So now there is reduction in the vasodilators, increase in the vasoconstrictors. Now this is what we've been told ever since our third year in MBBS, that there is an imbalance between the vasoconstrictors and the vasodilators. This is where we are talking now about that. So prostacyclin is reduced and thromboxane A2 is increased. So hence there is prostacyclin thromboxane A2 ratio which reduces, does not increase. It does not increase. All right. So that's why the answer to the question is D. You gave me the answer just because you already saw that one important line, then thromboxane A2 is low. You knew that's a wrong statement. So immediately you got the answer. Well done. So now I've derived that for you. So in total, what happens in preeclamptics? Vascular endothelial growth factor, placental growth factor. I'm so sorry. So vascular endothelial growth factor, placental growth factor, it reduces. Soluble FLT, okay, FMS like tyrosine kinase 1, endoglin will increase. Nitric oxide will reduce. Nitric oxide is also vasodilator, okay, vasodilator, and prostacyclin also reduces. All right. So this is the gist of the preeclampsia story. So guys, all right, guys. Let's move on and see the next question. Which of the following cervical encerclage procedures should be done in a non-pregnant lady with cervical incompetence? Come, guys. Yes, this is also a tough question. It came in your Inicet exam around a year back, 1.5 years back. Yes. What is this answer to this question? Yes, these are tough MCQs because mostly we're reading about cerclages as the McDonald cerclage, the worm cerclage, and if you're reading a lot, then we read about Shirodkar cerclage. But now they gave you these choices: Lash and Lash cerclage, Benson and Durfee, worms, and the laparoscopic cerclages. So yes, please remember, before you answer, I want you to understand one fact, that most cerclages which are done vaginally, we sometimes have to do the cerclages abdominally. Now, vaginal cerclage, abdominal cerclage. Some of these cerclages which are difficult to do from the vagina, they're easier done from the abdomen. So, most of us vaginal surgeons, we can do all the cerclage from the vagina. Even a high cerclage we can do from the vagina. We can open the vault and get into the peritoneum and put a high cerclage through the vagina. So, yes, do not get into this big confusion about shall I do it vaginally, shall I do it abdominally. If you're a good vaginal surgeon, you can do it vaginally, all the cerclages, or you feel that it's easier for me to open the abdomen and put a cerclage. So guys, the questions coming to you are about cerclage during pregnancy or cerclage before the woman gets pregnant. That's the only part which you have to concentrate on in this chapter. Once again, whether you want to put it vaginally, whether you want to put it abdominally, that depends on the surgical acumen of the surgeon. Then, whether you want to put it abdominally, if you want to put it abdominally, do you want to cut the abdomen and apply it, or you want to put it laparoscopically? That's still again surgical acumen. So how you apply the cerclage is not generally going to be your question, because it's a very big area of discussion, because some surgeons are very comfortable putting, like how you do a hysterectomy, you do an abdominal hysterectomy, but we do for prolapse vaginal hysterectomy. Now, there are many of us who can do a vaginal hysterectomy without any prolapse. There's no prolapse, there's a non-descent vaginal hysterectomy. So we can do vaginal hysterectomy from the vagina without any descent. The uterus is in its place, high in the vagina, and we can still do a vaginal hysterectomy, because that is the surgical acumen of a surgeon. Once again, We are talking about the types of cerclage, whether we put it during pregnancy or before pregnancy. How you apply the cerclage, don't get into that confusion. All right. After knowing that, now let's get into this answering. So what have you guys answered? Okay, you guys are not answering, and I think I was waiting. Okay, fine, you were listening. Fine. Lash and latch cerclage, Benson and Durfee cerclage, worm cerclage, laparoscopic cerclage. So, done in a non-pregnant lady. So, before I tell you the answer, let me just show you the list of cerclages. So, first, okay, the answer is already here, lash and lash. I'm sorry, it's already written here. So, yes, lash and lash cerclage is the classical prenatal cerclage. We generally put lash and latch because it's a traumatized torn cervix. So to do a correction of that kind of a cervix and open the vault and do a surgery, it's very difficult to do in a pregnant patient, because pregnant patients will be more having more congestion of blood, there will be more vascular cervices, so they'll bleed a lot. So that's why lash and lash is classically done before the lady is pregnant. Okay, so let me tell you, classical McDonald cerclage. Yes, the cervix is short. So if you see the cervix like this, and this is the nice and long cervix of woman. Now this is a short cervix, but you have a place to apply the cerclage. So yes, when you have this short cervix, you can apply the cerclage here, and that's the classical McDonald cerclage. Now, when you're applying the McDonald cerclage, that's the most common cerclage. Now, what is the Shirotker cerclage? Now, Shirotker cerclage, all of us have read about it a little bit, but let me try and tell you, it is about very short and a mutilated cervix. So, you don't have a cervix like this length of a cervix. If it is so long, like, you can easily put a McDonald here. So this kind of cervix we don't have. Now let me just show you here. The cervix here is much shorter. The cervix is so short here that you don't have a place to apply the cerclage. Yes, this is the position, and there is the bladder in front, the rectum at the back. Yeah. So I'm slicing a woman. And showing you in a sagittal section from the right side. So if you have to put a stitch here, can you see somewhere here I have to put a stitch at this level? See, I'm drawing a blue line here. This is where I have to put a cerclage, but this part is not inside the vagina. So yes, now you have to understand that I have to dissect out. Okay, I'll draw this in red now. This part, can you see this part of the vagina, and this part of the vagina is now removed. Okay, we have to remove this part of the vagina. We have to open this part of the vagina and then expose the cervix, and then we can get inside and apply the stitch here. To apply the stitch here, we have to open the anterior and the posterior vagina, apply the stitch on the cervix, and then close the anterior and the posterior vagina. So Shirodkar is a much more complicated stitch. We can apply during pregnancy. Even as recent as 3 days back, I have done a Shirodkars in my hospital for a woman who had 3 abortions, and the cervix is very short, and we hardly have any place in the cervix is hardly visible. Any part of the cervix hardly visible, just the opening of the cervix was visible, and no anterior posterior place. So we had to dissect the anterior posterior vagina and apply the stitch and re-suture the. Now the problem is, when you re-suture the vagina, the stitch is above the vagina. Can you see? The stitch is here. So that's why Shirodkars, that's what is likely going to be your next question, cannot be removed. Cannot be removed because you have now closed the vagina below the stitch. This McDonald's, this is applied. McDonald's applied after 12 weeks of pregnancy. It is removed after 37 weeks of pregnancy. Why do we remove the McDonald's? So that the woman delivers vaginally. Now this cervix, in a case of Shirodkar, is so small, then it's a difficult surgery to do to apply the stitch, and you cannot remove it when the patient is in full term pregnancy. It will be a very vascular surgery, and she'll bleed and have a torrential hemorrhage if you try to do stunts to just do a vaginal delivery. All right. So that's why it cannot be removed. The delivery is by a cesarean section. Delivery is by a cesarean section. All right, guys. Right. That's about the Shirodkar. So now about the other things which I was trying to tell you. There is something called the cervicoisthmic cerclage here. See at this area, cervicoisthmic, it's even higher than the Shirodkars. So this cervicoisthmic cerclage, also known as the Benson and Durfee cerclage. It's for extremely short lacerated or amputated cervices, originally done in pregnant women, but now can also be done in non-pregnant women. So this pregnant and non-pregnant, you can put the Benson and Durfee. But the lash procedure, man cerclage, page wrapping, not even going into the techniques about this, all of these are done in the pre-pregnant state. So I've given you the list. Please keep it, mug it up, or understand it, what you want to do. Please remember lash and lash procedure, which I told you, the man cerclage and the page wrapping technique, various methods of doing cerclages, and more extensive surgeries. And for that, a lot of dissection is involved, and that's why a lot of bleeding happens even in a non-pregnant woman. So that's why these surgeries are not done in pregnancy. These are classically done in pre-pregnant. The cervicoisthmic cerclage, the Benson and Durfee, can be done in a pregnant woman. Classically, it was done in pregnancy, but also can be done in non-pregnant woman. Yes, this one Benson and Durfee I've done, only one I've done in my life. I mean, it's a very complicated thing. I did not do in pregnancy because we had to open the vagina and go very high at the level of the descending uterine. We had to go in cervicoisthmic cerclage is very high. So that's why it was a very difficult procedure we did in a non-pregnant woman. Benson and Durfee, right? So yes, a lot of new names, guys. Okay, what are you guys answering? You guys are not answering now anymore. Okay, guys, never mind. So, do you want to ask me something about the cerclage? Yes? Anything about the cerclage you want to ask me? I gave you quite a bit in this session. Anything you want to guys ask? Okay, that's it. Yes. Let's move on. Which of the following is not done in active management of third stage of labor? Right, guys, hot shot question, controversies. Let's start fighting. Come on, guys. Okay. Come, come, come. This is the one which I was waiting for. What are you guys saying? Which of the following is not done in the active management of third stage of labor? All right. Come on. Okay, there is at least one B. Dheeraj Pandey. Everybody else is saying, okay, Shivangi is also saying B. Rest everybody saying A. All right, guys, I'm so happy that you said A. Okay, those two of you who said uterine massage, please, uterine massage is integral to the management of PPH and prevention of PPH. Please, moment you take out the placenta, okay, a lot of B's have come in now, okay. Moment you do the control cord traction and take out the placenta, after that the uterus has to contract, you have to give a gentle uterine massage. And yes, I know your WHO says that you should not be doing the uterine massage because it takes a person a lot of time to give to this patient who is delivered. One doctor who has delivered a woman, and now he is in a situation in, let's say, in a war-torn country, let's say maybe like Syria, where there are hardly any doctors. So WHO is writing for many types of countries, not just for India. So WHO says that if you have a doctor who delivers a patient and then is going on massaging the uterus, when will you have time to see the others? So there has to be a dedicated health person. So those are the lines. You have to understand what WHO is writing. So I'm not saying WHO is wrong, but we don't believe blindly what WHO says. We have enough doctors. All right, we have enough doctors, and around 70,000 are going to write another exam to become gynecologists, out of which at least 10,000 are going to be gynecologists. Okay, fine, at least 7,000. So if there's so many gynecologists coming every year and there's so many interns and so many residents who are there, we have enough doctors to give uterine massage. And please remember, active management of third stage labor involves massaging of the uterus. Please go to any labor room. All you interns, I'm very, very sure those who are interns here and post interns, you have worked in your labor rooms, and in your labor rooms, in front of the labor room, any labor room will have this big chart of PPH management, and there it will be written. I was in one of the classes where I showed straight away a picture. I asked an intern sitting to get a picture of his labor room. He called his final year student's friend, and they took a picture of the PPH management from their hospital. I'm not naming the hospital, and that picture which came, it had clearly written, please give IV oxytocin and give uterine massage and do delayed cord clamping. All right, so please, you have to do uterine massage. Okay, so those who said early cord clamping, your answer is correct, that we don't have to do early cord clamping, we have to do delayed cord clamping in India. Okay, the answer to the question is early cord clamping. Please give uterine massage. Please do control contraction, and you give uterotonics after placenta delivery. Of course, you have to give it prophylactically also, but this is what is very important. Do uterine massage and do not forget about that. Now, something I want to tell you about PPH management here. Late cord clamping is at least 30 seconds, but most of us are doing 1 minute. So at least 1 minute you should be doing. All pediatricians are very happy. Moment the baby comes out, keep the baby a little lower than the body of the mother, so that some placental blood comes to the baby and his hemoglobin improves by 1 gram %. And then you will give administration. Before that, of course, when the anterior shoulder comes out, moment the head comes out and the anterior shoulder comes out, you give the oxytocin. Okay, so first is oxytocin, and then when the baby comes out, you do the delivery of the baby, and after that do a late cord clamping. Then after the plaster comes out, do a gentle massage of the uterus. Okay, now please remember one thing. Which one of this, please answer, which one of these four things which I am telling you? One is giving oxytocin, then the delayed cord clamping, then the uterine, the control cord traction, and then the uterine massage. Which one of these four is the least important? Which of these four is least important out of these four? So the cord clamping, whether you do early or you do late, it has no bearing on the PPH. Yes, the least important of all of this is the early or delayed cord clamping. Yes, we should do delayed cord clamping. We are Indians and we have pregnant mothers who are basically anemic. An anemic mother losing a lot of blood. So we are worried about that also. So we are managing the PPH very actively and we don't want them to lose a lot of blood. But at the other end of the discussion, we also have that baby should get some more blood from the placenta. So yes, we've all agreed to do a delayed cord clamping in our country. You know what is classically taught by Williams obstetrics? Yes, you'll be surprised to know I've taken the the privilege and the chance of putting straight from Williams this page for you. Okay, the Bible for Obs and Gynae and my reference book. It clearly says that do early cord clamping. It clearly says that. So that's why the next part of the discussion is very important. Active management of third stage labor consists of early cord clamping, control cord traction, and immediate administration of prophylactic oxytocin. All right. As noted earlier, delayed cord clamping does not increase postpartum hemorrhage rates, and thus early clamping is the least important component of this. All right. So please understand, we are very sure that do uterine massage, but the other part, the early or delayed cord clamping, is not very important. It does not have a very strong bearing on the amount of PPH. But do delayed cord clamping. What William says is not wrong, but that's a developed country. In our country, we want babies to get more blood. So we will stick to delayed cord clamping. All right. So I'll not confuse you anymore, guys. Please remember, what are you guys asking me? Yes. Oh yeah, Arjun. Yes, yes, you're right. Uterotonic given after field delivery, not plasma delivery. Yes, I agree to that. You know, that's this I've just written as the way it came in the exam, and I also realized while I was reading, maybe the choices could have been formatted better. Okay, point taken, guys. The question while I was reading in this presentation, this has been given straight from how it came in the exam. So it should be after delivery of the anterior shoulder. I showed you that, but the choice should have been better formatted. Agreed. Chali, let's move on, guys. Now, just to prove a point, just one last minute, just to prove a point, this question came in Inicet November 2022. See this question. Arrange the sequence of third stage of management. Okay, again there are some mistakes in this recall, but I'm just trying to tell you what question came in November 2022. After that, this confusion has actually reduced whether we should do uterine massage or not. Look at the choices, guys. This is Inicet November 22. Check for the second baby, oxytocin 10 units, control cord traction, uterine massage. put them in the correct order. Now this question came in Nicet. So you have to put the order. Of course, you know the order is A, B, C and D. That is the answer to this question. But what am I trying to tell? I'm trying to tell you that they have asked you about uterine massage. Okay, uterine massage, please put in the correct order where uterine massage is done. So obviously we are doing uterine massage, that's why we are asking you to put it in the correct order, just to give you a strong reason to believe what I was telling you, that uterine massage should be done. All right, enough. Let's move on to another important question regarding PPH. Yes, okay, let's move on, guys. Regarding PPH, which of the following statement is incorrect? Okay, or better way, all of the following are correct about PPH management except like that. So, excuse me. Okay, loss of more than 500 ml of blood in vaginal delivery is PPH. All right, fine, this is correct. Again, the choices are not very well recalled. Initial replacement by colloids, 4 times the amount of blood lost. Not a very not a very strong statement. I'm not very happy about this one. Then chorioamnionitis, multiple pregnancy and prolonged labor are the risk factors. Correct. By adding 500 ml for each 3 volume % drop in hematocrit, that is, if the hematocrit is, let's say, 33% of a woman before delivery, and it comes down to, let's say, 30% hematocrit comes down. So for this 3% drop, for each 3% drop, add 500 ml to know the volume of blood loss. Okay, so this is also correct. So I'll give you the answer. The wrong choice is B. All right, so much of replacement by colloids is not done. We give colloids, we give fluids, but it's better to give blood if it is available. Now, why I chose this question to discuss about the added blood volume in pregnancy. Now, this is that question which keeps coming once in a while, but it came in the exam and most people miss this one. So, what is this added blood volume? Fundamental. When a woman is non-pregnant, how do you calculate her blood volume? 50 into height in inches, 25 into weight in pounds divided by 2. Now, that is a non-pregnant blood volume. Let's say it is 5000 ml, let's say, of a average height, average weight woman. A woman adds around 50% to this blood volume in pregnancy. Let's say she adds 2500 ml of blood to this, and she becomes 7500 ml in pregnancy. So this is what happens in a normal pregnancy. Now, if blood loss is less than the pregnancy added volume, the hematocrit remains the same. What is the meaning of this statement? Suppose the hematocrit was 33. Before delivery, the hematocrit was 33% and she bleeds in delivery. When she bleeds in delivery, she bleeds, let's say, 500 ml or 1000 ml or 1500 ml. This is already taken care of by the increase in the blood volume of pregnancy. So the hematocrit does not drop. So if the blood loss is less than the pregnancy added volume, please see this pregnancy added volume, that is 2500 ml. So if this is less than the pregnancy added volume, the hematocrit does not drop. If post-delivery hematocrit is lower than the hematocrit before delivery, then the blood loss can be estimated as the sum of calculated pregnancy added volume plus 500 ml for each 3 volume % decline of the hematocrit. The choice 4 of your MCQ. So yes, if suppose a woman was 33 hematocrit, she is 40 weeks of pregnancy, her hematocrit is 33%, she delivers and she loses a lot of blood. And when she loses a lot of blood, now you know how much of blood loss has happened. To know that, what do? You do a hematocrit. Hematocrit comes to 27. From 33, it is gone to 27. So, if the hematocrit from 33 has gone to 27% after delivery, so the person has lost that 2500 ml of blood, okay, plus 500 ml for each 3 volume % drop. So she's dropped 6 volume % here. So that is 500 for 3, another 500 for the next 3. So she's lost another 1000 ml of blood. So the total blood loss is 3500 ml in this woman. All right, that's a massive obstetric hemorrhage. Okay, and anything more than 2000 ml 2,500 ml of blood loss is known as massive obstetric hemorrhage, and that's why we have to know how to calculate it, how to calculate the blood loss based on the hematocrit, and this is to also keep in account the added blood volume. So the what is the funda of the added blood volume? That a woman adds around 50% of her blood volume in pregnancy. All right, right, guys. Okay, that was a tough one, but then it keeps coming in the exam. Now let's see the next easy question. Okay, so this is what happens in AIMS. I told you they'll ask you complicated stuff, and then suddenly they'll ask you a very simple question. Quadruple test consists all of the following except beta HCG, inhibin B, unconjugated estriol, or alpha fetoprotein. It looks all right. All of them look right to me. Anything which is wrong? Oh yes, you guys are actually, you were listening to the theory part, and suddenly you started answering. Oh, you are there still. Okay, fine. Thanks, guys. So yes, you are correct. Inhibin B is wrong because it is inhibin A. Yes. So quadruple test is unconjugated estriol, alpha fetoprotein, inhibin A, and HCG. So unconjugated estriol, it is from whatever is the median value. There is a median value we have. Median value, let's say we do this test at 16 weeks. We have a median value which could be, let's say, X, Y, Z. Okay, maybe let's say an M here, whatever, any alphabet you can give. So median value of these. And now what happens to unconjugated estriol if the patient has a trisomy? So what happens here? This estriol is lesser than the median value. Alpha fetoprotein is lesser than the median value. Inhibin A increases more than the median value. HCG increases more than the median value. So yes, I keep telling you that IN for increase, H for high. So inhibin A increases, HCG is increasing, and that's what is suggesting that the patient may have a Down syndrome. So or any other aneuploidy. So when a patient has these median values, and this median value for so many women is, let's say, X, Y, Z, and M. So this median value in the patient which we are talking is more. HCG is more than the median value, and inhibin is more than the median value. Alpha fetoprotein is lesser, unconjugated estriol is lesser. So how many multiples of median it is more? How many multiples of median it is less? So that's why this question came in your PSM exam, that which of the following tests uses the MOM units. Okay, so this MOM units are used for the triple marker. Another test, yes. Do you want to tell me where else do you have this MOM units used? Anybody in the class? Yes? Anybody in the class where you use MOM units? In obstetrics at least. Yes, it's in the, yes, peak systolic velocity. The peak systolic velocity of the middle cerebral artery when a patient has a baby with RH isomnization and hemolysis. So the peak systolic velocity increases from the median value 1.5 times, 1.5 MOM units. More than that is suggestive of a high peak systolic velocity, indication for you to terminate the pregnancy or give a blood transfusion. All right, guys, let's move on. Which of the following is a specific complication of monochorionic twins? Yes, that's a simple question, guys. Come, tell me. Excuse me, as you give the questions, answers. Okay, specific complication. So yes, all of these complications like preterm labor, discordant growth, IUGR can happen in twins, but monochorionic twins will have the chance of a deep arteriovenous anastomosis causing the twin-to-twin transfusion syndrome. So that's what is specific here. So the reason is a deep arteriovenous anastomosis. Okay. So Also in monochronic twins, you can see the twin reversed arterial perfusion. We can see acardic twinning. These are all very specific things which you can see in monochronic twins. So monochronic twins, if you see, we are worried. Okay, this monochronic twins. Okay, where's that picture gone? I'm missing a picture here. All right, in monochronic twins, this one placenta is shared between two babies. So when there is this sharing of the placenta, monochronic twins can have these so many vascular complications causing problems. So monochronic twins have a much higher incidence of both the twins dying. Okay, so we say if it is a monochronic gestation, if it's a monochronic twin gestation, then we deliver by 34 completed weeks. Yes, we are happy that we achieved 34 weeks, lungs are mature, and this is done by cesarean section. Okay, dichorionic and diamniotic, deliver at term, and the plan is vaginally. Of course, if there are some problems, then all pregnancies, any woman who is pregnant, when she comes to me in the OPD, my plan is to do a normal vaginal delivery for her. And of course, during labor, if there is a fetal distress, I end up in a cesarean section for this. That's a different story. But plan is to do a normal vaginal delivery. So dichorionic, diamniotic, the plan is to do a normal vaginal delivery for these twins. Of course, if the babies are by breech, both the babies, first baby is breech, I'll do a cesarean section. So plan was to do a vaginal delivery for dichorionic, diamniotic. Now monochronic twins, the plan is to do a cesarean section at 34 weeks. Sometimes I do the cesarean at 32 weeks itself. I give steroids by 32 weeks and do a cesarean, because sometimes waiting from 32 to 34 weeks for the lung maturity is a little risky. So we give steroids and do the cesarean at 32 weeks itself. So monochronic twins, we have to thank God that we could reach, because this malformation, these vascular malformations can make us lose both the babies. One baby will be very small and anemic, other baby will be very big and polycythemic, and both can cause intrauterine fetal death. All right, so deep arteriovenous anastomosis, if you have a good ultrasound, 3D ultrasound with a Doppler and a good radiologist, you can pick it up, and then we can do ablation. If you diagnose this in time, let's say 16 to 18 weeks, 20 weeks, you've diagnosed this, then we can ablate this malcommunication. All right, this deep arteriovenous anastomosis, we can do a laser ablation. All right, so yes, all those things are there, but if you're not able to do that and you know that there is a monochronic twin, then you will deliver by 32, 34 weeks. All right. Right, guys, the signs seen by 8 weeks of pregnancy, which are these signs of pregnancy? Goodell sign and Osiander sign, lightening, internal ballotment, which are seen by the 8 weeks. It's a fairly simple question. So Goodell sign is the softening of the cervix. Hagar sign is softening of the isthmus. Okay, softening of the cervix is Goodell's. The single O, not Goodell's. It's Godels, I think. Anyway, so Goodell sign is softening of the cervix. Osiander sign is pulsatility in the lateral fornicis. So these are two which are seen by 8 weeks. So yes, all of you got that correct. A is the answer. Lightening is when the head gets into the pelvis. When the baby's head gets into the pelvis, the mother feels a little lightening. So engagement, which generally happens around 36, 37 weeks. In a primigravida, engagement happens by. In a multigravida, when does the engagement happen? It happens in labor. Sometimes it happens as late as, when the cervix is fully dilated. So multigravida will have a pendulous abdomen. So the abdomen will be having a very loose abdominal muscle tone. So the baby will be a little, bent forwards. So pendulous abdomen. So the head doesn't get to the pelvis. So when the labor, when the uterus gets into good labor, that good labor now finally gets the head to come aligned with the pelvis, and the head gets into the pelvis in advanced labor in a multigravida. In a primigravida, it happens around 36 to 37 weeks. That causes lightening of the, the feeling of lightening. All right. So yes, when do you see internal ballotment? When do you see external ballotment? Yes, come. That's not mentioned here. Come on, tell me, guys. Internal ballotment and external. Somebody already asked me PCM, sorry. Okay, yes, when do you see internal ballotment, when do you see external ballotment? It's a good question. Internal ballotment is that if you have the fetal head like this, if this is the pelvis and the head is like this, ballotable, all right, you can do a per-vaginal examination. With the per-vaginal examination, you hit the head of the baby. You hit the head of the baby, it goes up and it comes back. So through the cervix, not in the cervix, from outside of the cervix, all right? Don't try to open the cervix with your fingers. Just tap the head. So the head will go up and come and hit back on your fingers. That is internal ballotment. And external ballotment is outside of the pelvis. So external ballotment is like you, in the lower abdomen of the mother, you hold the head and you do this. So when you move the head like this, it's like a ball. So you tap from this side, it goes and hits the other finger. Tap from this side, it goes and hits this. So this is known as ballotment. So external ballotment. So internal ballotment is earlier, okay, and external ballotment is later. So what did you guys say? Oh, you didn't answer. You're listening. Good. So internal ballotment is 16 weeks to 18 weeks, and external ballotment is around 20-22 weeks. All right. Right, guys. So, oh, you stopped answering. You're listening, guys. Chalo. What is the usual timing when this procedure can be started? What is the time for this procedure to start? Okay. See, there's a baby here, and this baby is now having a, this is the uterus. Okay, let me try and show you the walls. This is the uterus here. This is the amniotic cavity, and the placenta is here. This, the placenta is here. Okay, it's, I'm writing red in red, so you're not seeing. Okay, let me see. The placenta is here. Okay, so maybe it's easier for you to see. You're using a needle here, and this needle is going in like this here, somewhere here. Okay, now that the diagram is a little bit clearer for you guys, come tell me when you do this procedure. Yes, guys. Are we having some answers? Okay, let me refresh. Yeah. जाके चार्जर ले मेरे बैग में टेबल पर 11 to 14 weeks. That's a wrong answer, my friend. 11 to 13 weeks. No. So what is the procedure going on? So the procedure here, see, I drew the diagram better for you to understand. The procedure going on here is the amniocentesis, and the amniocentesis is best done. Amniocentesis best started at 16 weeks and later, after completed 16 weeks. So 16 weeks to 18 weeks is the time for an amniocentesis and a chorionic villus sampling. If the needle was here into the placenta, we can put a needle into the placenta through the abdomen. We can put it from the vagina also. You can do a transabdominal CVS or a transvaginal CVS. So chorionic villus sampling is done around 10 to 13 weeks. Okay. Now there is something called the early amnio. We didn't ask you that. Early amniocentesis, that is done at 13 to 15 weeks. So see, it's easy to remember. 10 to 13 chorionic villus sampling, 13 to 15 early amnio, and 16 onwards is the amniocentesis, which is the correct time to do the amniocentesis. All right. So amniocentesis 16 to 18 weeks, classically for diagnostic purposes. Of course, therapeutic amniocentesis we can do even at 24 weeks if the patient has polyhydramnios. 28 weeks, like that we can do. All right. So not to worry about that part. But amniocentesis for diagnosis can be done as early as 16 to 18 weeks. Early amnio is done at 13 to 15 weeks. Okay, guys. Chalo. A midwife is examining. Okay. A midwife was examining. Again, a grammatical mistake here, guys. Beg your pardon. A pregnant woman, suddenly she noticed a prolapsed umbilical cord. So there was no labor, that means. The patient was being examined by a midwife, and suddenly there's a prolapsed umbilical cord. Yesterday somebody was asking me, so I made sure there was this question in the discussion. So when there is a prolapsed umbilical cord, which of the following should not be done? What should not be done? Come, tell me. Now this answer I want. What are you guys saying? Chordocentesis 18 weeks. Gopika, 18 weeks onwards, chordocentesis can be done. Good. Not to do. Put her in Trenenberg. You want to do, you don't want to do. Don't you dare touch the cord. PCM, you're talking like me. I am so happy. Don't you dare touch the cord. Yes, please. Should not be done. Okay. Immediate manual replacement of the cord. Don't touch the cord, please. You're going to cause vasospasm and vasospasm. So you may have a compressed umbilical cord which has come out of the vagina. It may be compressed between the head and the pelvic brim, or it might be the breech and the pelvic brim. It might get compressed as it is. So if the baby is alive and then you hold the cord and you try to push it beyond the head, you're going to cause more vasospasm and more damage. So never manually replace. So I don't know why I was in a class and I said that what should you be doing for a patient who's got a cord prolapse. Some 2-3 students got up and said, sir, hold the cord and put it back inside. That's what is done. And I said, where do you get that from? So something, please understand, you never hold the umbilical cord. All right. So please remember, Trendelenburg position, that is head low. The woman is straight like this. Give a head low position so that the presenting part goes, you go higher in the abdomen. The head of the baby, if it was at the pelvic brim, or the breech of the baby, if it is at the pelvic brim, it will go away from the pelvic brim and the cord will not get compressed. So you can give a Trendelenburg, that is the head low position, and the patient is best kept in a lateral position, that is left lateral or right lateral, and then the patient can be helped by filling the bladder. When you fill the bladder, from the urethra, you can put a catheter and fill the bladder. Put in around 500 ml to 1 liter of saline you can put in the bladder, and that will promote the head getting higher in the uterus. It will prevent the head going into the pelvis, a big bladder. So all of us know a full bladder will prevent engagement of the head. So that's why in labor, women are encouraged to empty their bladder. So that's why if you fill the bladder here, it will encourage the head to go up. So yes, you can fill the bladder to elevate the presenting part and inform high authorities and ship the patient directly to the operation room for management. Don't manage this patient in the labor room, because you may have to, mostly cord prolapse ends up in a emergency cesarean section. So please don't manage this patient in the labor room. So yes, take the patient to the OT, do a Trendelenburg position or a lateral position, and of course we can also fill in the bladder to prevent the head pressing on the cord. Do not touch the cord. Okay. Okay. So that's the yes. Now this is the this answer given here is manual replacement cord is the answer. Here the choice, this answer is wrong here. So those who have seen this in the recording, I didn't want you to remember this. Please, you must fill the bladder. Okay, so don't look at this. Okay, so this is what was sent to me by somebody, so that's why I think I should have not written this. Okay, please fill the bladder to take the head away from the brim. So this is the Royal College guidelines. This is nothing from me. This is the Royal College guidelines, the green top guidelines. I've given this to you. The optimal management of cord prolapse in fully equipped hospital setting is, okay, insufficient data to manual replacement of the prolapse cord above the presenting part. Okay, this practice is not recommended. Okay, so you should not do manual replacement of the prolapse cord. To prevent vasospasm, there should be minimal handling of the loops of cord lying outside the vagina. To prevent cord compression, it is recommended that the presenting part be elevated either manually or by filling the urinary bladder. So you can fill in the urinary bladder. Okay. Cord compression can be further reduced by the mother adopting the knee chest position or the left lateral position, preferably with the head down and pillow under the left hip position. All right. So all procedures done to prevent the head pressing the cord or the breech, if it is the presentation, to cause the cord compression. Okay, mostly they'll end up in a cesarean. Of course, the patient is the second stage and there's a cord prolapse, then you can apply a forceps and quickly take out the baby. You can do that also, but that is, the cervix should be fully dilated. Okay, this is that picture which was misplaced. This is what I was trying to tell you, the monochronic one, and this picture, I don't know how it came here. So this is the the monochronic diamniotic, monochronic monoamniotic twin here, and in this monochronic monoamniotic twin, you may have a deep arteriovenous anastomosis here. Okay. Anyway, so milk suppression in pregnancy is brought about by which of the following? Next question, guys. Come, we'll come to this one. Yes, guys. I'm waiting for your answers. This was also an ICT question. This is now, suddenly the tough questions will come. Milk suppression pregnancy is brought about by which of the following? Okay, B, a lot of B's. Asani, Urvashi, and okay, fine. Oh, suddenly deluge of B. Some A's also. The Lion King, wrong answer. B is the correct answer. All right. So high estrogen and progesterone, mostly the progesterone, is what is inhibiting the alpha lactalbumin. Okay. So let us see. The answer is B. That is the progesterones and the estrogens, but mostly the progesterones. So what happens? What is the cause of milk production increasing after delivery? So abrupt reduction of progesterone and estrogen, removal of progesterone influence, removal of progesterone influence, I did not write that word, influence, removal of progesterone influence on alpha lactalbumin production. Okay, so this alpha lactalbumin production is reduced because of progesterone, and that inhibition is gone after the woman delivers. There is a progesterone withdrawal after delivery of the woman, and prolactin stimulation of the alpha lactalbumin production. So these are the events which are postnatal, which help in the formation of the breast milk. All right, guys. Now, there was this question about Manning score. There were some choices which it was not recalled properly, so I have not mentioned the choices. They were very funny and not related. So I'm just asking you, what is the Manning score? That's what this purpose of giving this line is, only to ask you what is Manning score. Forget what was the question. If you know Manning score, then you'll know what I'm going to ask you. Yes, who is going to tell me what is Manning score? I'm sure the radiologists are telling you about this, but then Gopika, Lion King, yes, that's the correct answer. From where I get this PDF? PDF will be given, my friend, of all the PDFs we are now recording, and they are given to the prep team. If you're not getting the PDF, then send in a message. I'm sure they'll give it to you. Don't worry. Backend team guys, my friends want the PDF. I hope you give that the PDF to the students in time. Okay. FHR, fetal heart rate evaluation, is not the Manning score. Okay, it's the biophysical profile, the full biophysical profile. So biophysical profile is also known as the Manning score. So whatever choices came regarding the biophysical profile were not appropriate in this question, so I'm not mentioning. So yes, this was given only to check if you know what is the meaning of the Manning score, that is the biophysical profile. So biophysical profile, I'm giving an interpretation here so that we can answer questions which come based on this. So biophysical profile, you know, it is a fetal movement, fetal breathing. What is fetal breathing? A baby is inside the mother. A baby is inside the mother. Do you think the baby is breathing? So the baby is swallowing the amniotic fluid. Moment the baby swallows amniotic fluid, it's like, you know, when we swallow, our chest expands a little. Of course, not so predominantly for adults like us. So when you're doing an ultrasound, you know, you put an ultrasound wave on the side of the chest of the baby, through the mother's abdomen, you see the chest. Moment the baby swallows, the chest expands a little. So that looks like a breathing movement. It's basically the fetal swallowing which appears like breathing. So fetal breathing, fetal movement, fetal tone, okay, and the amniotic fluid index along with the non-stress test. So these are the 5 parameters of the Manning score or the biophysical profile, and the perfect biophysical profile is 10 by 10. So biophysical profile of 10 is a normal non-asphyxiated fetus, and if the biophysical profile is 8 by 10, but there is a normal 8 by 10 with a normal amniotic fluid index, so that's a normal baby. So sometimes the biophysical profile might be 8 by 10, but the amniotic fluid index, if it is okay, then I'm happy. So that's why we say, if the non-stress test plus the amniotic fluid index is good, then we are happy about a pregnancy. So that's why we have the modified, this is what is known as the modified biophysical profile. All right. So if, let me just tell you biophysical profile now. I'm sorry if I mentioned the modified biophysical profile earlier. So Biophysical profile of 10 is good. 8 with a good AFI is also good, but 8 with a low amniotic fluid index is hypoxic baby. 6 possible fetal hypoxia, 4 possible fetal hypoxia, 2 certain fetal hypoxia. So this is what we always say. Till 8 by 10 we are at least discussing whether the baby is good or bad. Let's see the Likert. We are at least talking. Anything below 8, that is 6, 4 and 2. Okay, we never have a biophysical profile of 7 and 9 like that. Okay, the score is either there or not there. Either it is 2 or it is 0 for fetal breathing, 2 or 0 for fetal movements. So there is no 1. Okay, there is no in between values. So the values are 0, 2, 4, 6, 8 and 10. So if the biophysical profile is 6 or lesser, then the baby is certainly not good. Plan a delivery or a cesarean if the baby is too bad. But if the biophysical profile is 8 or 10, then we can discuss. Okay, less than 6 and less, we are not even talking. Right. Basic punchlines of management. Okay, repeat test. For what you said repeat test, Dr. Tanya? Okay, fine. We will discuss all that later. I hope you are able to read this. This is a little small in print. Yeah, you're able to see this. The following instrument has what specific use in obstetrics and gynecology? I'm not telling you the instrument. You have to see this instrument, recognize the instrument. I've given you enough views. The tip of this instrument and the side look, that this instrument has a lock I've shown you. Then a real pic of this instrument from my hospital. So yes, tell me what is the use of this instrument? Who are you guys answering? Oh, by the time I explained the instrument, everybody has just flooded the chat with C's. All right, very good. I'm so proud of all of you. You know these instruments because you've been reading well. And you've been assisting in cesarean sections. Yes, guys, this is indeed the green Armitage. This is a green Armitage. Okay, green Armitage is for holding the edges of the uterine incision in a cesarean section. Okay, let's see if this video is playing here. Yes, guys, if you see this is the green Armitage application. Yes, guys, yes. See the edges here. This is the edges where we are applying this. Okay, see the angles, of the uterus. So the angles of the uterus where we apply this green Armitage. So the uterine arteries sometimes might be involved in the incision. So that incision, if it is extending too much, the angles may have involved the uterines and bleed a lot. So this is a nice broad based instrument with serrations, and it gives a good compression of the artery. Even if there is no bleeding, the edges are held by the green Armitage. Yes, most of you interns, you know very well that this green Armitage is mostly not used. The senior resident or the resident who is doing the cesarean is very happy using a Alice forceps because it is lighter and smaller in size. But the instrument to be used is the green Armitage. All right, green Armitage is the name of the surgeon. Okay, it's not the Green Army. It is Green Armitage is the name of a person. Okay, guys. Okay. Use regularly in OBGOT. Okay, fine. Good, Gopika. I'm so proud of you. Very nice. So, yes, that's the ideal instrument. Okay. So, this is, I just thought I'll tell you a few instruments. This is the Doyne's retractor, the best friend on the interns in the Department of Obs and Gynae to retract the bladder away from the lower uterine segment. Okay. To make a lower uterine segment incision, all of us know very well the lower uterine segment here. If you can imagine, the bladder comes in front of the lower uterine segment. So, if I have to make an incision here, if I have to make an incision in this part, the lower segment, you see the bladder is coming in the way. This bladder is in the way. So, what we do? We empty the bladder. We empty the bladder before the cesarean. We encourage the woman to void. Most people like to put a catheter, which I'm deadly against. So, don't put catheters in a patient where you're not going to do any surgery on the bladder, all right? Or if you injure the bladder, maybe and repair it and put a catheter. But elective catheterization is elective introduction of infection. Sometimes these questions are going to come in your exams. Don't give routine antibiotics to anybody who had a cesarean or a clean hysterectomy, okay? Only if there is a infection. So we always say induction antibiotics. That is, when you're giving anesthesia, give one dose of antibiotics in a clean OT. So induction antibiotics for cesarean, induction antibiotics for hysterectomies, and no routine catheterization. Make the woman empty her bladder, and after the cesarean, within 1 or 2 hours, the patient is even had a GA, she is conscious enough to get up and walk and go to the bathroom and void herself. Or if she's had a spinal anesthesia, she's not allowed to walk, then you can give her a bedpan and she'll empty the bladder herself without putting a catheter. All right, so don't do elective catheterization. So good, I got the chance to tell you that. Now empty the bladder and then you make an incision on this part of the uterus. So that is what is the idea. You have to make an incision in the lower segment. So to reach this bladder has to be pushed down. So when we push this bladder down, okay, when we push this bladder down, that bladder is held. This bladder, when we push it down, and now the bladder is here. Now this is the place where we, of course the abdomen is open here. This is the place where you put the Doyne's retractor, and then you can go and make an incision here. So this Doyne's retractor is helping us to do the incision in the lower segment. Okay, fine. This is the placement of the Doyne's. Can you see? This is the uterine incision. Here we've sutured it to show you. This is the Doyne's retractor here. It is putting the bladder away from the lower segment. All right, guys. Okay, a 26-year-old primary graduate at 37 weeks of gestation came to the hospital with complaints of high blood pressure and proteinuria of 3+. Okay, dipstick test. Excuse me, guys. What are the signs of imminent eclampsia here? Yes, guys. What are you guys answering? 1, APCD. 1 is wrong, guys. Pedal edema. Okay, pedal edema is never a sign of preeclampsia. Pedal edema can be there in most women who are pregnant. So edema is taken out from any diagnosis of preeclampsia. All right. So headache is there, blurring of vision, nausea, vomiting, of course. But here epigastric tenderness. These three, A, B, and D. Is there A, B, and D? Yes. Choice 2 is the answer. Some of you actually got it correct. So yes, pedal edema is not part of the answer. So headache, nausea, vomiting, blurring of vision, reduced output, exaggerated knee jerks, epigastric pain, and proteinuria more than 2 grams is also a sign that there is worsening proteinuria, and more than 3.5 is a sign of a patient having nephrotic levels of proteinuria, and blood pressure more than 110 diastolic. These are the signs that the woman might be throwing a convulsion, imminent eclampsia, guys. All right, so let's move on and see the next question. Dose of dexamethasone for accelerating fetal lung maturity. Yes, simple question, simple recalls will also come in exams. Yes, is it 12 milligrams 12 hourly? Actually, that's what I do in most of my patients, which is wrong. Okay, 12 milligrams is what I give, and I keep telling this to my interns so many times, and when they're writing the exam, they are like a little confused. So please don't give 12 milligrams. We do it in practice many times just to reduce the number of doses. The right dose is 6 milligrams. So whether you give it 12 hourly or you give it 6 hourly, or whether you give it 2 doses or 4 doses. So what is the answer, guys? C. Yes, 6 milligrams 12 hourly, 4 doses. Yes, 6 milligram 12 hourly, 4 doses, and that is 24 milligrams. So what is the dose of betamethasone? Betamethasone, yes, anybody? Betamethasone is, yes? Anybody wants to tell me? Let me see. All right. Betamethasone is 12 milligrams, 24 hourly, 2 doses. Again, it is 24 milligrams. So both the drugs are basically 24 milligrams. The dexamethasone is given 4 doses, betamethasone is 2 doses, and both betamethasone and dexamethasone are equally effective. Okay, there was a time when we gave only dexa, and then for good 5-6 years, the pediatricians, the gynecologists were giving only betamethasone, and now for the last 5 years, everything has been now seen that both of them have a good profile of action. So how do the steroids help in the lung maturity of the baby? Who is giving the steroids? The mother is giving the steroids. So how does the lung of the baby gets mature? Yes, I've been teaching that in the classes, on the app and on the live classes. So tell me, how does the betamethasone or the dexamethasone help in lung maturity of the baby? Yes. Yes, we have to give steroids. We have to give steroids. It helps in the lung maturity. How does it help? Come on, guys, tell me. Oh, come on, guys. You're not answering. Surfactant. Increase surfactant. How? Yes, it increases surfactant. How? So, yes, you give the steroids to the mother, the steroids go to the baby. And yes, what is surfactant? Surfactants is fats. Fats are what is going to reduce the surface tension. So, yes, to have a lung mature is to have fats on the lung. So, to increase production of fats, steroids will help. Steroids increase the production of fatty acids. So, more steroids, more production of fats, and lung will get mature in the baby. All right. So, yes, very good. Increase surfactant production, yes, correct. But we must talk about in terms of fats to understand that fats reduce the surface tension and steroids promote fatty acid synthesis. Okay. What is the right sequence of events of labor? Yes, I've not given all the events. There are 7 cardinal movements. I've given you 5. So yes, the question which came to your exam, they had given only 4 events. So seeing these 5 events, what do you think is the order? There are actually 7 cardinal movements. The next slide, I'll tell you all those 7 in the right order. That also has come in the exam. Yes, guys. How many are saying D? D for Delhi. All right, that was fast. Most of you got D. Some of you got E also. Yes, D for Delhi. Yes, I'm happy that most of you got it correct. D is the right. Okay, so yes, the cardinal movements of labor are engagement, descent, flexion, internal rotation, which happens at the pelvic floor. Delivery by extension, restitution is the correction of the internal rotation. So the correction of the internal rotation is restitution, and external rotation, the last one, it is one word. Okay, there are 7. 1, 2, 3, 4, 5, 6. External rotation is one word. Okay, so external rotation is the due to the rotation of shoulders on pelvic floor. All right, guys. Okay. Right. I think you got that correct. Okay, let's move on. A woman who presented with seizures at 30 weeks of pregnancy was started on magnesium sulfate therapy. What would be the first sign of magnesium sulfate toxicity seen in this patient? Easy question again, guys. Come, tell me. All right, most of you got that correct. Loss of knee jerks is indeed the first sign of. So the therapeutic range, yes, correct answer, guys. Thank you so much. 4 to 7 milliequivalents per liter is the therapeutic level of magnesium sulfate in the circulation. So if it goes beyond 8 to 10, okay, 8 to 10 causes the loss of knee jerks. So 8 to 10 is loss of knee jerks, and 10 to 12 is respiratory depression. More than 15 is respiratory arrest, and more than 25 is cardiac arrest. So these are the levels which you should be knowing, and more than 25 is cardiac arrest came as a question once. And what is the treatment? Yes, that you know very well. Antidote in your sleep, you know, is calcium gluconate, 10 ml, 10% over 10 minutes intravenous. Right, guys. HCG is structurally and functionally similar to. Yes. HCG is structurally and functionally similar to which one of these? This was a biochemistry question, but I took the liberty of putting it here. Yes, C, LH. So alpha LH is same as alpha HCG. In fact, it is also the same as alpha TSH. Keeps regularly coming in your exams. So yes, the gene for alpha subunit of the gonadotropins is expressed in both the pituitary and the placenta, the alpha subunit. Since it is coming from the pituitary and the placenta, it is not specific. So the LH, TSH, HCG have a similar alpha subunit. Now, the beta subunit for HCG is expressed in the placenta, and the beta subunit of LH is expressed in the pituitary but not in the placenta. So beta subunit of HCG is from the placenta, the beta subunit of LH is from the pituitary. So that's why it is specific. So these are different. So that's why when a woman is pregnant, we don't do HCG estimation. We do the beta HCG estimation because that is specific to the placenta. Okay. And when we're doing beta HCG estimation, nothing is similar to beta HCG. Suppose you do HCG estimation, just to do compound HCG estimation. What will happen? You will measure the HCG, but you'll also measure the LH because alpha LH is same as alpha HCG. So you will have a wrong value. So that's why you should do what is specific to pregnancy, and that's what you already know. I'm telling you the reason why it is specific, because the beta subunit of the HCG is coming from the placenta and the beta subunit of LH is coming from the pituitary. Okay, that's why the beta subunit is specific for pregnancy. All right, guys, let's move on. Which of the following constitutes the modified biophysical profile? So I already told you that. Please remember, the modified biophysical profile reduces the time of doing your assessment of this fetus, because biophysical profile should take at least 30 minutes to 45 minutes for your assessment. You know that non-stress test alone will take 20 minutes. Two accelerations of more than 15 beats above from the baseline lasting for 15 seconds at least. So that's what is going to take at least 20 minutes of the test. So along with that, fetal movements, fetal breathing, fetal tone, amniotic fluid index calculation along with the NST is going to take at least half an hour to 45 minutes. So just doing the amniotic fluid index and the NST, yes, all of you answering it correct, I can see that. Okay, no, not C, guys. Somebody is answering C. No. Amniotic fluid and NST. Okay, that is the modified biophysical profile, and it is just as good. We mostly have seen almost 90% as good as a complete biophysical profile. So it is an abbreviated biophysical profile, requires only 10 minutes to perform. You save on time, and it's a superb antepartum surveillance method because there were no unexpected fetal deaths. This is the study from a journal, and the modified biophysical profile is as predictive as fetal well-being, as predictive of fetal well-being, okay, as is the biophysical fetal surveillance. Okay, dose of carbetocin used in PPH management is, yes, that's a simple question. It came in your exams. Yes. No, A is not the answer, Dr. Chaudhary, and C is also not the answer. Oh God, some people don't know the dose. Okay, yes, carbetocin. Okay, it's a synthetic analog of oxytocin. Oxytocin maximum works for around 15-20 minutes. It contracts the uterus for 15-20 minutes, and that's why it's good enough to cause the uterus to contract. But sometimes the uterus is tired. It has been in labor for a long time, and that uterus, after the oxytocin action goes off, it gets relaxed again, and the patient may have repeat bleeding. So that's why when you have to have a sure shot action, nowadays people are giving carbetocin, and carbetocin will act for almost 1 hour to 2 hours, some books say. So it's got a prolonged, okay, it's got a sustained uterine contraction action, more sustained action. Okay, that's why it's a synthetic analog of oxytocin, and the dose is 100 micrograms, which is in 1 ml, and it is given over 1 minute. Okay, 100 micrograms, which is in 1 ml, given over 1 minute. All right, guys, B and D is the same. Oh, oh. Okay, I'll try to smile as my friend Anonymous is smiling. The grin. Yes, guys, B and D. Okay, I'm being very magnanimous. Two choices are correct. B and D are correct. I beg your pardon for the error here, guys. I should have seen this. Okay, let's move on. Of course, those who know the dose correct, I'm so happy for you. So 100 micrograms in 1 ml IV bolus over 1 minute, can also be given IM for longer effect. It's a synthetic analog of oxytocin. Fine, I already told you that. Now, the branches of the antidivision of internal iliac artery include, now come on, I need all the alphabets here. Come, tell me, guys. You know this very well because it's coming in almost every alternate exam. PPH, internal artery ligation, all of that. Please remember this regularly coming in exams. Yes. Branch of the antidivision of internal artery include all of the following except. So yes. So we always remember the posterior divisions. We remember the posterior division, and the posterior division are 3 branches. Yes, all of you giving me the answer. Yes, short gives you giving me the short form which I told you. So yes, superior gluteal, iliolumbar, and lateral sacral. So yes, these 3 are not the answers. Okay. Okay, so C, D, E, G, H. These are the branches of the antidivision of the internal iliac artery. The answer to this question is that. Of course, you guys know this well. I've given you the picture so many times. So remember, short gills, okay? Short gills. Fishes have short gills, like that I've written. Superior gluteal, iliolumbar, lateral sacral. Nowadays, the hot favorite, Shubman gills. Also, you can remember. Right, guys? So these are the branch of the posterior division. So we have to ligate which branch? Please remember, in PPH management, we are not ligating here. We are not doing the ligation here. No, we have to ligate the anterior division only. We ligate only the anterior division of the internal iliac artery, because the uterine artery is from the anterior division. So when we ligate the anterior division of the internal iliac artery, we are not ligating as a tight ligature. It is just a snug ligature. You know, it's a comfortable ligature to reduce the flow, not to stop the flow. So it's a snug ligature to reduce. We ligate it to reduce flow and not to stop. And this promotes thrombosis. This promotes thrombosis in the uterine bed. So you know, the placenta where you are taken off, the uterus just had a placenta here which was removed. The placenta was here and it was removed. Now when this placenta was removed, see this placenta here, when this was removed, so the base of the placenta here, this base of the placenta was bleeding. Okay, now this uterine artery, which is having a blood pressure of 120 to 80, that high pressure going to this, the clots will form. The clots will form normally, but what happens that the high pressure will dislodge the clots. So if the woman is having a PPH and the pressure is 120 by 80, I'm not saying she's a hypertensive, even 120 by 80 is dislodging these clots very fast. So we reduce the flow. We reduce the flow, and that promotes thrombosis in these bleeding blood vessels. All right. So the idea is to not to stop the flow, but to reduce the flow. All right. Right. So somebody was asking me yesterday the difference between true labor pains and the false labor pains. I hope that gentleman or the lady is here. Otherwise, whenever you see this, it's just for you, because I think I saw this query 3-4 times in the chat yesterday. So difference between true and false labor pains. True labor pains and false labor, okay, this should come as a heading, okay. So these are regular contractions associated with a bloody show. And bloody show, you know, the mucus plug which comes out with some blood when the patient is going to labor. It's a mucus plug which is grayish to black in color along with some blood. So that is what is a bloody show. So regular contractions which have a bloody show, frequency and duration will keep increasing with time, and it is accompanied with cervical dilatation. And if you give sedations, the labor is not going to stop. You know, her perception to the pain is going to reduce, but the pains are not going to stop. Okay. Now, what is false labor? These are irregular contractions and there is no show along with this, and there is no increase in frequency and the duration of the contractions with time. It is not accompanied by cervical dilatation, and his pain is lesser with sedatives. The whole episode will actually finish. You know, that's what classically we used to say. If there's a woman is having a false labor and you give her a painkiller, she's going to walk out of the emergency department in 1 or 2 hours and she can go home and sleep. So that's what happens in false labor. Okay, so classically the patient walks out of the hospital easily when there is a false labor pain. Of course, the only place where a true labor patient is going to walk out is to the labor room when she comes to the emergency with a true labor. Okay, so that's what I wanted to tell you today. But yes, you are free to ask me any questions you have in your mind, because wait, let me just save this first, because that's what I keep doing. I have this problem of keep. All right, I'll keep this, and then we can, yeah, we can go on discussing whatever you guys want to ask me. Okay, come, tell me. What are you guys asking me? I'm seeing it on the laptop today. Lion King in, okay, fine. Oh, you guys are tired, no? 2 hours of a class and all right. You guys, so what are you going to ask me? If there's something you want to ask me before we wind up for today, nothing is coming through. I guess that's about it then. We had a fairly long discussion about a lot of topics possible. PH and PPH, please read in the best possible way. aneuploidy screening, okay, dual marker by 12 weeks, triple marker by 16 weeks, quadruple marker 16 weeks, and dual marker is around 80%, 85% sensitive, triple marker is more, and quadruple marker is best. Sequential screening, that you do all of these together, then it is more than 90% sensitive in picking up a patient having aneuploidy. All right, so dual marker around 12 weeks, and triple marker, quadruple marker 16 weeks. And when you're doing this aneuploidy screening, along with that, we can also do nowadays NIPT. It is a screening test, non-invasive prenatal testing. It's a screening test, not a diagnostic test. It is 98% sensitive, but 2% it may miss a aneuploidy. So that's why we say NIPT is not a diagnostic test. It's a screening test. It's an expensive screening test. It's around 15 to 20,000 rupees in the market even now. It started at around 55,000 rupees around 10 years back. Now it is down to 15 to 20, but still it's a good screening test. If this comes positive, then we do diagnostic tests. All right. So yes, what else you guys want to ask me? Preeti ma'am, you're still here, are you? Thank you so much. Right, guys, I think most of you are saying thanks, and it was wonderful taking your session, guys. Do your exam very well. When you're preparing for a NEET exam, you should go and write your INICET exam. Prepare for a NEET exam very nicely so that INICET exam does not bother you much, because INICET exam will have the same topics, obviously, but the exam questions is full of easy questions, and that occasional tough question which is going to, give you the rank. So don't spoil the easy questions. That's what I keep telling you. The easy questions in INICET are just the straightforward questions, and you sometimes get so perturbed that how can they ask such an easy question in a major exam like this. Yes, it is intentionally asked. Those questions, you must know that out of those 75% questions, you should get all of them correct, and the remaining 25% tough questions are going to formulate your rank. All right, guys, so that's my carry home message after this. And anything else, you can always get back to the Prep Ladder team and ask them to forward your queries to me, and we can find a forum to come and do the discussions before any exams. So do well, and all the best for exams. Thank you so much for staying up.